Hi there. Today I want to talk about something that is really rooted in my role as a social worker and what drew me to that field. And one of the things that social work does is orient you to the larger systems and how it affects the individual. We talk about person and context. And our context on a global scale is one in which where trauma is something that is widely experienced as part of the human condition, and yet accessing people who have expertise in providing support is very small. There is a tremendous global gap in care. Here in the West, obviously, we have more resources than a lot of other parts of the world, and yet we still struggle to get the majority of our population the supports that they need, particularly in specialized areas. So, for example, people with DID, OSDD, complex trauma, and PTSD, they're often told they need a specialist. And then they go to seek one out, and they're too expensive, they're geographically concentrated, and have long waiting lists. And also, those who most need the support based on marginalized identities and things like that are also those who are least likely to have access to it. So, we've built this model of care that says you need specialized treatment, but most people can't get there. Also, structural dissociation, which is my area of specialty, is not widely taught. Many clinicians leave grad school with minimal education. In fact, without it even being mentioned. It was not mentioned in my graduate program, I have to say. So I learned about it after, and I pursued my own additional training after grad school because I was myself passionate about this work. Many clinicians do not have that luxury, and that obviously trickles down to survivors who need some support. So, if specialists cannot possibly serve everyone, how do we expand the circle of people who can help? Or if we have advanced interventions, but the majority of the traumatized global population cannot access them, what good are they actually? These are questions to begin to ask ourselves in the context of our current mental health infrastructure. So, expanding the workforce, though, does not mean replacing therapists or pretending every provider can do specialized DID treatment. But what about creating an ecosystem of care? Specialist therapy, generalist therapy, pre-licensed clinicians, coaches, peer support specialists, psychoeducation, skill support, community health workers, and other types of paraprofessional roles can really potentially contribute different things in different ways, and all of those ways are meaningful. And if we think about trauma as sort of a departure, an abandonment from humanity, where we feel like we needed to be helped and there was nobody around to help us, the recovery that includes our community can be potentially extremely healing, and I might even argue more healing than therapy in itself, because we're creating a foundation of support around an individual. So what about task sharing? Task sharing is where um, specialized providers share some of their tasks with paraprofessionals and pre-professionals, community health workers, etc., who have training within a particular area of focus. These providers can reside in their communities and are much more culturally accessible and relatable than professionals for a lot of folks. Task sharing is endorsed by the World Health Organization and has begun to be, well, it started to be studied I think it was in the 1990s, I believe. And since then, it has been applied in resource scarce areas throughout the world. And this is certainly something that could apply to any area, that we're relying on those within community to help those within that community. So there is this, I also have this concern about the professional hierarchy. Like sometimes our field is quick to dismiss pre-licensed therapists simply because they're pre-licensed. There's a lot of fear around people who are not therapists at all providing support, but we know that peer support is very effective, and that coaching calls and DBT are very effective and supportive. So the stuff that happens outside of therapy can be incredibly meaningful and supportive. And also years licensed do not automatically equal specialized competence. A well-supervised pre-licensed clinician who is actively studying dissociation may know more about recognizing and responding to it than someone who's licensed and who has never received any kind of training in this area. So we don't want to just assume that licensure means competence in this area. Peer support specialists, coaches, community health workers, and other support roles are sometimes dismissed before we seriously consider what they can safely contribute. And regarding safety, the answer is not, of course, that anyone can provide support around navigating dissociative disorders. But the answer is thoughtful training, scope of practice, role clarity, supervision and consultation, referral pathways, and coordination with therapy. So coaching, for example, can be complementary therapy. It can potentially support skills practice, routines, goals, self-agency, connection, and really have some degree of accountability in there that the therapist may or may not be able to provide support around. So perhaps we sometimes confuse protecting clients with protecting professional territory. I know that that's something that might feel uncomfortable to hear, and it is uncomfortable to say. However, it's very likely that this is part of the picture. And therapists are not disposable. However, every other profession in the West that I can think of, dentists, doctors, nurses, they all have assistants, nursing assistants, dental assistants, physician assistants. There are layers of support around one specialist, and therapists are the only ones who I can think of that do not have that kind of extra support around them, and at the same time seem somewhat territorial around their work. I want to talk a little bit also about the reality of the 1 hour a week therapy model, where this is somehow assumed to be the ideal. Well, this is not an ideal if most people cannot access it. So we want to talk about what is real versus what is, again, ideal. So most people around the world cannot go to therapy 1 time a week. It doesn't mean that more therapy is always the answer either. It might mean that we broaden our network of support and add different kinds of supports versus having this one idea about how we can provide some solutions and support to those who are really profoundly suffering. So I would say that every clinician does not need to become a DID specialist, but far more clinicians need foundational competence in recognizing dissociation, screening for it, pacing it, stabilizing our clients and working well with them, and knowing when to seek consultation or refer. But also we could use some extra support, and so could our clients in the work. And also regarding the responsibility of specialists, expertise should not only be used to treat individual clients. Specialists can teach, supervise, consult, create frameworks, and help other providers become more competent. The way I do that is I use technology to make my information more accessible to more people because I don't have to be in one place at one time. I can really share my information more readily and much less expensively. So that's how I approach it. Also doing these videos and sharing knowledge is part of that model. But we don't want to necessarily dilute expertise. It's to diffuse knowledge. And that's kind of what I'm trying to do with you here now, and also what I would promote as a solution to the gap in care problem. And if our model requires every person with DID to have continuous access to a highly specialized therapist, we again have created a model that most people will never have access to. So closing question, how do we maintain safety and quality while dramatically expanding the number of people who are equipped to help? Thank you so much for listening. I hope this was thought-provoking, and take good care.